Hello students, welcome to our class. We are doing the OBGY final shot FMGE, now postponed to January 2022, from where we are streaming. Are we live? We'll just confirm whether we are live or not. Yes, I think so. And can I also please get a confirmation in the chat box, all those who are over here, so that I know whether am I audible to all and am I visible to all, and is the chatbot function working? Yes. Hello. Okay, so welcome all of you to our session. I'm Dr. Punit Bhojani. We're here to discuss some of the very important upcoming FMG. Now all of you know December exam has been postponed to January, so please make the maximum of it, and we are here to discuss some of the hot topics, important topics and important MCQs. Just a couple of points before we begin. So this NEET PG 2023 Achievers batch, all the first batch 500 slots for full, so on popular demand. Okay, starting 30th of November. It is your preparation along with test and discussion, doubt clarification until 30th of November. This is a highly discounted price. Please use the code MENTOR, MENTOR. All those who haven't yet subscribed, kindly use the code MENTOR to get this discount, and it will really be helpful for your preparation, not only for NEET PG but also for the upcoming FMGE examination. Okay, and year wise, first year, second year, third year course are available, and depending on your requirement you can go for a 2 months, 3 months subscription, which is going to be available at a highly discounted price, and the code remains the same, MENTOR, MENTOR. Please use the code MENTOR to get the maximum discounts. Okay, and compete is there, where you can just download the Unacademy app and you can battle with your partners to see who is doing well in the competition. Okay, so various subscriptions available as per your requirement. The code remains the same, MENTOR. Okay, so with this, let us begin our discussion. All of you know the advantages: best lectures, best teachers, live classes, recorded lectures, anytime, anywhere, along with the study material also. Iconic subscription also available, and you know the features of the class. We conduct polls, you can raise the hand, directly speak to me during the lectures also. Okay, so with this as the background, let us begin the discussion. I want all of you to participate in the poll. Right, wrong does not matter. So all of you, yes. So I got a first MCQ for the day, and it's a clinical case. Okay, so case-based MCQs have started coming. So it's a clinical case. 16-year-old girl has not yet attended menarche. So by 16 years also she has not yet got her periods. What is it? So it's a case of primary amenorrhea. Okay, so we have got primary amenorrhea, complaints of pain in her lower abdomen for few days at the same time. Any clue? Anything ringing? Same time every month. Why should she get pain? Okay, what is that pain which she's getting for few days? And along with it, there is also urinary retention. Why should there be urinary retention? And this condition would be seen with which condition? Anybody? Okay, Dr. J is saying 3, Gowda is saying 3C. Very good. Okay, so this is imperforate hymen. Okay, why? All will explain to you. Please pay attention. Okay, Asherman syndrome. Anybody? What is? So we'll discuss one by one. What is Asherman syndrome? Asherman syndrome is intrauterine adhesions. We get mainly because of excessive curettage, repeated curetages. So in that, generally the sequence is patient has got her periods, then the period starts becoming scanty. So Asherman syndrome gives rise to hypomenorrhea, scanty periods, and then the periods can stop. In severe condition the periods can stop, and then that would be secondary amenorrhea. Okay, so students, remember, Asherman syndrome is an example of secondary amenorrhea. Testicular feminization and RMKH are also the more common cause of primary amenorrhea, but they will not have cyclical. Please understand, this is like a same time, so it's a cyclical pain. Okay, cyclical pain, and they will not have urinary retention. So this is imperforate hymen. This condition is also called as cryptomenorrhea. Okay, is this understood to all of you? Cryptomenorrhea means hidden. Crypto means, the word crypto means hidden. Okay, so anybody, basically what happens over here, please pay attention. Yes, this is the image based question. This could also be coming in your upcoming examination. So the same thing you get, all of you please pay attention this picture. So what happens is that there is the uterus, there is the cervix, there is the vagina, and the hymen is imperforate. There's no space for the blood to come out. So whenever the menses will start, anybody, what happens? The menses will start, but they are not able to come out. That's the reason why the patient gets cyclical pain and like a period crampy pain. So she's getting pain, but the periods are not coming. What will eventually happen? The blood gets collected inside the vagina. What is this condition called as? Anybody? The blood will start getting collected inside the vagina. So what is that called? That is called as hematocolpos. Okay, blood, colpos means vagina. Okay, is it understood to all of you? Then the blood will get collected inside the uterus. That is called as hematometra. And long standing, this is, what is it? It's called tense bulging hymen. Okay, when you examine the patient, this is a clue. Bulging hymen. Okay, and bluish purplish. All of you can appreciate it. The hymen is bluish purplish. Okay, so what happens is that it is a bluish purplish hymen. Okay, it is a bulging hymen, bluish purplish hymen, and this all, okay, this colpos, this colpos, hematocolpus and all this can compress the trigone on the base of the bladder and can cause urinary retention. Okay, so tense bulging bluish purplish hymen is what you classically get. And what is the treatment? Anybody? What is the treatment over here? You are just supposed to take a cruciate incision. Okay, so if this is the hymen, this is the bulging hymen, and you take a cruciate incision, the flaps will open up. You take the incision and then the blood will start coming out. Okay, so all these points please keep in mind. You are just supposed to make a nick like this and make a nick like this. Okay, so all the blood which is there inside will start coming out. Okay, is it clear to all of you? Yes. So nothing more, so keep all these points in mind. And just by the way, the important MCQ over here, by the which also comes in the exam. Anybody? RMKH syndrome, what is the karyotype? Very famous MCQ. RMKH syndrome, what would be the karyotype? Anybody? RMKH syndrome, Rocketanski Mayer, it is 46XX. Please keep in mind, very famous MCQ. And testicular feminization, it is testes, so it is 46XY. Okay, that is how you differentiate between the two. Okay, is it clear to all of you? One of the main differences that karyotyping is different. Both of them are primary amenorrhea. In that case it is absent uterus. Okay, they have got absent uterus. Okay, so option 2 and 4, it is absent uterus. Okay, let's go on to the next question. So this is a very important, and this picture also asked in the recent one of the exams, so please keep this picture in mind. Okay, yes, again a clinical case based scenario. We have got a lady who has come for preconceptional counseling, and which of the heart disease is not an absolute contraindication to conceive. So there are certain heart disease which are very dangerous, and those patients should not plan a pregnancy, should not conceive, else there can be a problem. Okay, so anybody, which of the following heart disease is not an absolute contraindication to conceive? Yes, anybody? Okay, Afrin Menon is saying 2, no Afrin. Okay, Adil is also saying 2, no. Okay, so all of you please pay attention that this is no. Eisenmenger syndrome is very dangerous. Yes, WPW syndrome is the answer. Just happen pathway. In this condition, the patient can continue with the pregnancy. Why? Others are dangerous. So please understand this, that whenever we have heart disease in pregnancy, heart disease, there is something, you need not remember the whole table. There's something called as Clark's classification. is a Clark's classification based on mortality, maternal mortality. Okay, in all heart disease, the mother can die. Okay, heart disease is very dangerous during pregnancy and the mother can die. So but certain heart diseases, remember students, like ASD, VSD, PDA, only 0 to 1% mortality. Okay, is it clear? So those patients can plan a pregnancy, they are allowed to conceive. Similarly, aortic stenosis, mitral stenosis, even NYHA 3 and 4. Okay, so you need not remember this whole table. Okay, here there is slightly more mortality, but the most dangerous, please understand this, what I want you to remember for the exam, these four, they are called as the most dangerous heart disease because there is maximum mortality. Okay, so please understand this MCQ has been asked repeatedly in different exams by only the framing of the question is different. Whether they ask you most dangerous heart disease, same answer, maximum mortality, same answer, worst prognosis, also same answer. And in which of the following pregnancy is contraindicated, also mean the same answer. Is this understood to all of you students? So all these four, most dangerous heart disease, maximum mortality, worst prognosis, pregnancy contraindicated, there are four which you need to by heart. What is that? That is pulmonary hypertension, both primary and secondary. So primary pulmonary hypertension, and anybody what is secondary will lead to? What will secondary pulmonary hypertension lead to? Anybody? And what is this Eisenmenger's syndrome? So Eisenmenger syndrome, all of you remember students, that initially if there is left to right shunt, then there is development of secondary pulmonary hypertension, and that would lead to reversal of shunt. Okay, so right to left shunt, is this understood to all of you? So initially there is a left to right shunt, and then it is yes, Prince Davis, very good. Okay, and then there is a reversal of shunt. That reversal of shunt, so it's very dangerous and patient can have a lot of poor prognosis and the patient can die. Okay, so right to left shunt, that is reversal, and that reversal is because of this secondary pulmonary hypertension. Okay, so this is called as Eisenmenger's. And similarly the other two are this Marfan syndrome with aortic root dilatation, because during pregnancy, during labor, the whole aorta can tear and immediately the patient can die. And similarly one more very good, coarctation of aorta with valvular involvement. Okay, coarctation of aorta with your valvular involvement. So all these are very dangerous conditions. WPW does not come into that. WPW is just your aberrant pathway and an arrhythmia which can be managed in pregnancy, so not so much of a contraindication. Okay, moving on to the next question. Yes, this was again asked in the last year's FMGE exam. Which of the following is an indication for surgical management of ectopic pregnancy? Anybody? So please understand this, that in ectopic pregnancy, okay, anybody, what is the treatment of choice? Anybody, can anybody tell me what is the treatment of choice? What is the preferred or the first treatment of choice? Yes, okay, yes. So what the treatment of choice is? Methotrexate. Okay, today we avoid a surgery. Okay, we avoid a surgery and we try to treat it with medicines only, and we try to avoid. Okay, we try to common sense, we try to avoid a surgery. So the first treatment of choice, or wherever possible, okay, wherever it is possible, we prefer giving methotrexate injection. So can anybody tell me, there are some criteria for methotrexate which needs to be fulfilled, then only I can give methotrexate injection. What are those criteria? Yes, so the criteria is the most important. When I want to give methotrexate, common sense, all of you tell me, can I give it if it's a ruptured ectopic? If it's a ruptured ectopic pregnancy and the patient is in shock, then will I give methotrexate? No, never. Then I have to go in for emergency surgery. Is this understood to all of you? So whenever it's a ruptured ectopic, so point number one, when I want to give methotrexate, patient should be hemodynamic. I'm writing HD. Okay, hemodynamically stable. Okay, HD stable matlab hemodynamic stable. That means it's a unruptured ectopic pregnancy. Second, very good, the gestational sac as measured on ultrasonography should be less than 4 centimeters, and the beta HCG level, anybody, till what beta HCG we can go for the injection methotrexate? Anybody? Yes, very good, Prince, Afreen, all of you. Yes, Adil, yes. Anybody? What is the HCG cutoff? So HCG level should be less than 5,000 micro international units per ml. Remember this. Okay, so if it's less than 3,000, so 5,000, and preferably the fetal cardiac activity should be absent. That means it should not be a live ectopic. Remember, this is slightly, you can avoid remembering this, because if the cardiac activity is present, methotrexate is a relative contraindication. It's not that you can't give it, but the success of methotrexate is slightly lesser. And anybody, the most important, after giving methotrexate injection, how do I know my treatment is working or not? How do I know that the treatment is working or not? What do we monitor after giving methotrexate? After giving the methotrexate injection, what do we monitor? Yes, very good, Durva Susar. We have to monitor the HCG levels, and they should keep on decreasing. Yes or no? It should be decreasing. Okay, so if you see over here, patient hemodynamically stable patient, very good. Okay, absence of cardiac activity, very good, and levels of less than 1,000, all are good. The sac size, okay, which of the following indicates surgical management? That means when I will not give methotrexate and prefer to go for surgery if the size is more than 4 centimeter, the 4-5 centimeter, it's a big ectopic, more chance of rupture, and methotrexate may not work. Okay, but overall methotrexate success is good. It's around 90% of the time. You just need to counsel the patient that she should be able to reach the hospital very soon. If any signs of collapse, you have to explain to her, anytime you get giddiness, a collapse, severe pain, acute abdomen, please rush to the hospital. Okay, so remember students, in ruptured ectopic, we prefer to do emergency surgery and salpingectomy. Okay, salpingectomy is the gold standard surgery. Okay, is it clear to all of you? When it's a ruptured ectopic, then salpingectomy is done as a life saving, and another tube is there, there's nothing to worry about. Okay, so patient can conceive with the other tube. Okay, yes, again a very important MCQ likely to be coming. 19-year-old unmarried girl comes to us at 10 weeks for MTP. What are the best option, or what is the best option to do MTP in this patient? Anybody? Okay, Afreen and Atul and Prince, can anybody tell me mifepristone misoprostol is used for termination of pregnancy only up to 9 weeks? Is this understood to all of you? So had this patient instead of 10 weeks, agar question paper was 6 weeks, 7 weeks, 8 weeks, 9 weeks, then definitely answer would have been option number A. Is it clear to all of you? But that's not the case. Okay, so see how one word, because then you want to avoid a surgery. Yes or no? You want to avoid a surgery. So we will not do unnecessary surgery. So when the patient is 6, 7, 8, 9 weeks, up to 9 weeks, meso works very well, because bigger pregnancy, then there is lot of bleeding and lot of retained products. So this would have been the answer if it was up to 9 weeks of pregnancy. Okay, but at 10 weeks. Now, extra amniotically ethacridine lactate, this was also asked in the recent INI-CT. Please understand, this is like almost outdated thing because it's not easily available. But by the way, this extra amniotic ethacridine is used for second trimester MTP. Okay, when the pregnancy is say 14, 16, 18 weeks, then we may want to use this ethacridine lactate. Okay, it's a yellow color liquid which you put it extraamniotically. It causes the membrane to separate and causes the contraction of the uterus. Okay, and MTP is not contraindicated just because she is an unmarried girl, and you don't have to. Okay, if you are more than 18, the patient can come and patient herself can give the consent, and it's okay. By chance if she become pregnant, it's our duty to help her. Okay, when do you inform the police is when if it is a minor. If it's a 16-17-year-old girl, then you know that having sex is not legally allowed, and then you need to just inform the police, but still you can go ahead with MTP. Okay, so MTP contraindication is not even there also. Okay, so by chance if it's less than 18-year-old girl, then you may want to you should inform the police, but you can go ahead with the MTP anyways. Okay, so MTP contraindicated ऐसा नहीं होता है, but if it is just because she is unmarried, majority patients who come to us for abortion are all unmarried also, so that is not a problem. Unmarried girls can of course have MTP if it's an unplanned pregnancy. So you don't need to inform the NGO and local police and MTP content. That is wrong. Okay, is it clear to all of you? MIFI, MISO. So the answer is MVA, manual vacuum aspiration or suction evacuation. We just wish that the patient should have come slightly earlier to us, so that we can even avoid the surgery. The surgery which is done in operation theatre. You can't, okay, you require operation theatre, you require sedation, anesthesia, you dilate the cervix with Hagar's dilator and suck out the pregnancy. Okay, is it clear? So 10 weeks hai, so between 10 to 12 weeks. Okay, basically the question is between 10 to 12 weeks, this is the option for termination of pregnancy. Okay, MBA or suction evacuation. Okay, next, very simple MCQ, all of you should know this. We have got a patient who has come to us at 28 weeks, anencephaly and AFI 30 centimeters, so that is polyhydramnios, more like her. Okay, is it clear to all of you? So the question is, all of the following are mechanisms of increased liquor in this patient except. So basically the causes of poly in anencephaly that they are asking you, that why anencephaly, which is what is the defect in anencephaly is what? Anencephaly is a kind of a open neural tube defect. So what happens if it's an open neural tube defect? And there are two other things which you should keep in mind. Yes. Okay, yes, very good, Afrin Menon. Okay, please understand uteroplacental very good, Adil Mohammed also. Okay, uteroplacental insufficiency is going to cause oligohydramnios. Okay, oligohydramnios is the uteroplacental insufficiency. Okay, going to cause or leads to oligo. So 1 2 3 1 2 3 1 2 3. Now please pay attention one by one. In anencephaly there is absence of swallowing. Okay, what happens is because baby passes urine and baby swallows the same thing. Okay, baby, so you can remember the symbol. Okay, baby passes urine, this, and then baby swallows the same thing. Okay, all of us have done the same thing in the intrauterine life, so remember this figure. Okay, remember the symbol yo. Okay, so that you will remember. So in wherever baby cannot pass urine, liquor will be less. Wherever baby cannot swallow, liquor will be more. So absence of swallowing leads to more liquor. Absence of fetal pituitary. So what will happen if fetal pituitary is absent? If fetal pituitary is absent, is going to be absence of ADH. Is this understood to all of you? So if there is absence of ADH, there is going to be more passage of urine. Is it clear to all of you? Absence of ADH. What is ADH? ADH is a antidiuretic hormone. Okay, so if antidiuretic hormone is absent, and there is more diuresis. Is it clear to all of you? So basically the fetal urine output is going to be more. Is this understood to all of you? And of course, since it's an open neural tube defect, if it's a defect is there, then the CSF will enter more into the amniotic chamber. Okay, is it clear to all of you? So I repeat, transudation of CSF, absence of swallowing, and absence of ADH, which leads to more diuresis. There's diuresis. Okay, there's more urine output, more urine from the baby. All that will cause poly in this patient. Okay, yes. One more very simple question. Can anybody identify this image based picture? What is this? Which condition this is most likely to be seen? 1, 2, 3, 4, all of the above. And what is the main treatment for this condition? Anybody? Yes, this is black velvety patches of the skin, mainly seen at the nape of the neck or in the axilla. This is acanthosis nigricans, and this is the marker for insulin resistance. So you see it in obese patients, you see it in diabetes. It's one of the markers for insulin resistance. So you likely to be seen in PCOS, not endometriosis, not dermoid cyst, not all of the above. Okay, and what is the treatment? Yes, weight loss, lifestyle modification, and of course metformin is the medical management what you can give. You can give in the dose of 500 milligram OD, then BD. Okay, 500 to 1000, but main treatment is weight loss, and metformin can also be used. Okay, so acanthosis nigricans, it is insulin resistance. It also leads to your future metabolic syndrome or syndrome X. Okay, metabolic syndrome X. So keep these points in mind. Okay, yes. Okay, yes, we'll have time for one more MCQ. Yes, hysteroscopy is indicated in all of the following except. So hysteroscopy, all of you know, is putting in a telescope. Hysteroscopy is but a NEET PG 2022 का तो अभी जो yes the batch is Adil, we have just recently conducted a batch last time, and we are again going to have this one for the upcoming exam test and discussion batch starting. Yes, very good, Prince Devos Afrin. Adenomyosis is the answer. Can anybody tell me what is adenomyosis? So please understand, students, hysteroscopy is a condition whereby we put in a telescope through the cervix into the cavity of the uterus to see the cavity. So if there is, what is Asherman syndrome? Sir, Asherman syndrome is intrauterine adhesions. Very good. So there hysteroscopy will help me not only in the diagnosis, also for the treatment. What is the treatment for Asherman syndrome? The best treatment for Asherman syndrome is hysteroscopic adhesiolysis. Okay, so all of you can see, we put in a telescope and with the scissors we cut the adhesions. Okay, so like this, just like this, see, like this. Okay, so you can see like how we are removing the adhesion, how I'm erasing the adhesions like this. All that adhesions will get erased, all that adhesion will be broken like this. So that is how the hysteroscopy is going to help me. Is it clear to all of you? Yes, so hysteroscopic adhesiolysis I can do in Asherman syndrome. Any patient who is having menorrhagia also we can come to know, because in menorrhagia, sir, there could be a polyp, there could be a fibroid, which are the causes of menorrhagia. So menorrhagia also, and all this thing, adhesions, septum, there could also be a intrauterine septum, fibroid, polyp can also cause infertility. So in all these cases, hysteroscopy may help us in evaluation. Adenomyosis is what? Sir, adenomyosis is presence of the endometrial glands within the myometrium. I repeat, in adenomyosis there is menorrhagia, mainly dysmenorrhea, but you do ultrasonography and very rarely even MRI, but ultrasonography is the initial investigation. Okay, this condition, you try medical management, you can try LNG IUD, you can try NSAIDs, you can give symptomatic treatment, progesterones, but unfortunately adenomyosis, if they ask you definitive treatment, is hysterectomy, removal of the uterus gives you definite benefit. Okay, so adenomyosis is the condition where the endometrial glands, all of you know the endometrial glands, this endometrial glands have grown within the myometrium. So endometrial glands within the myometrium. So everything is within the myometrium basically. So what is about the cavity? Sir, cavity is going to be normal. Is it clear? So no point doing a hysteroscopy. Hysteroscopy will be normal. There is no advantage of doing hysteroscopy. Okay, is it clear to all of you? At other moment, always transvaginal sonography is preferred. Okay, whenever I want to see the pelvis, always transvaginal sonography is always preferred. Okay, is it clear, Atul? Okay. Is it Adil Mohammed? Okay, is it clear to all of you? Yes. So that is our time. Thank you very much for coming in today, students. I hope it was very, very useful session. We discussed one and so many, around 6, 7, 2, 3, 4, 5, 6 and 7 MCQs we were able to discuss in a span of 30 minutes. So that was, I hope it was very, very useful to all of you. Do not forget to take the subscription as soon as possible using the code MENTOR, MENTOR. Okay, and see you in all that. So just download the Unacademy app, follow me regularly. Just finished one batch. December again we are starting with the test and discussion and also image based questions, and lots of upcoming sessions are there. Even recorded videos are going to start very, very soon for the benefit of all the students, so that you can see the complete recorded lectures. Okay, and iconic subscription also is available. Okay, yes. Is it clear to all of you? Yes. So, but the next class, Adil Mohammed, the next class will be notified when the next class is there coming up for YouTube session. Also, we'll let you know. And for this month, the sessions are over, and YouTube sessions will again be happening in the upcoming months. Okay. So, mentor is the code, and I wish all of you best of luck for the upcoming exams, and see you soon in the upcoming sessions, and see you also on the Unacademy app in the plus classes and special classes. Bye bye. Best of luck. Thank you very much.